Thank you. Thanks, Ian. Yeah, I actually don't have any of the stuff from the provincial, but just FYI, we've just gone through the final approval through BC guidelines. So the current stuff that's up on the provincial website is about 5 or 6 years old, so I won't show you any of that stuff, but it should be released within the next month. So yeah, just a little plug there. You know, I have a few folks in long-term care. I don't profess to be as expert. I certainly don't have the day-to-day experience that you folks have. We'll walk through some of this stuff, and I think I've left a reasonable amount of time for questions. So, you know, older adults are different. They aren't studied in clinical trials, and per my friend and mentor Grady Maneely from UBC, again, the concept of the frail elderly versus the well elderly, and I'll show you in one circumstance where I break from that. So the keys, I often talk in the office about balance, the balance between high blood sugars and low blood sugars. It's a very Zen sort of thing. I had a patient once ask me, what's worse, highs or lows? To which the rebuttal is, which of your children do you love more? Now, there may be an answer to it, depending on your children. I don't know that there's one in my house, although it perhaps varies from one day to the next. They don't live with me anymore. Individualize. So, you know, I can only please one person a day. And also thinking, and also thinking shorter term. So we spend a lot of time in diabetes management, you know, telling people about all the horrid things that'll happen to them 5, 10, 20 years down the line if they don't listen to us. And of course, in frail elderly and in nursing home folks, the, you know, long-term has a different definition. So, you know, we'll talk about short-term outcomes in diabetes, which we're probably appropriately criticized for not talking about enough. So these will be the themes that will come up through the next little bit. So I first did this when Tom Bailey and Peter Innes asked me to come and talk 2 or 3 years ago. So the Nova Scotia guidelines were prominent at that time, and I'll talk about them. 3 years ago, there was very little in the Canadian Diabetes Association literature. There's now more. I'll show you some of that. I'll show you some American stuff, and then most recently, a European group has come out with some published stuff. And then I'll try to bring it all together at the end. So the Diabetes Care Program of Nova Scotia looks at essentially all aspects of diabetes care. They're one of the few provinces that pretends to have a provincial program. BC has never really pretended to do that, so we're sort of left on our own. So these are available online if you search this. And they go through a number of aspects of care in elderly long-term care facilities. And this is one of their documents that up front I'll tell you I don't like. So this sort of goes through an algorithm in terms of, you know, if the blood sugars are this, do that. So the idea that, you know, a patient has a blood sugar, and they don't say how many, less than 7 millimoles, that one should decrease the therapy. They say a range between 7 and 10 may be acceptable, but then the green is between 10 and 20, with the caveat that this is acceptable if the resident has no reversible symptoms such as polyuria and nocturia. And I can tell you that anybody with a glucose over 15, because that's the renal threshold for glucose, is in fact going to have symptoms. So they're somewhat contradictory in their own document. So that's what I take issue with, and I'll explain as I go along why I think that's important, and that polyuria and nocturia as short-term symptoms are in fact bad things. So yeah, so the renal threshold. So for those of us who remember when we had, you know, patients stick little strips of paper in their urine, well, that has now largely been overcome with glucose monitoring. It does in fact tell us something.
Does the renal threshold vary with the renal function, especially in the elderly?
I don't know that. My understanding, there is certainly some variation, and one of the new classes of drugs changes the renal threshold. But I think it still holds fairly true that glucosuria kicks in at about that sort of range. This is a position statement from CDA. So this is a political statement, but one that we use to go forward to governments and other agencies for, quote, institutional care. So institutions include nursing homes and long-term care facilities, but also group homes, hospitals, and correctional facilities. Actually, diabetes care in correctional facilities is usually really good. So people with diabetes have a right to timely, affordable, and ongoing diabetes education and comprehensive treatment, coordinated by a healthcare team and per the guidelines. So, you know, we shouldn't compromise on these people. They deserve quality care as well, despite what some of my colleagues, including my office partner, say on occasion. So there is a chapter in the 2013 guidelines. They have been updated. Grady Maneely is the current but outgoing chief of internal medicine at UBC. He's a geriatrician by training with a research interest in diabetes. So he's the guru, and he's the lead author. Now, this is not specific to nursing homes, but it certainly touches on it. A clinical frailty score, something that I wasn't acquainted with, but I assume that you folks are. So Grady, being a good geriatrician, you know, refuses to treat all 80-year-olds the same. And so, you know, Grady differentiates the frail, probably beginning at about category 5 there, from the well elderly. So Grady won't talk about specific ages, but he will talk about frail elderly versus well elderly. So this comes from the guideline, and the reference is touched down there in the bottom, but it's embedded within that chapter that I showed you. Oh, sorry, I should have backed that up. Just guidelines.diabetes.ca is the reference, and then you can go chapter by chapter. So I'll go through these again, per the fact that the CDA tries very hard to make things evidence-based. They try very hard to be transparent in what they recommend. A lot of this is grade D consensus, right? So it means, you know, there's not a randomized clinical trial specific to this age group. Even a cohort study could get you a grade B or C recommendation. So this is the best they've got. So yes, healthy elderly should be treated to the same targets. Frail elderly, while avoiding symptomatic hyperglycemia, right? So again, there's your polyuria, polydipsia. They say a glycemic target in A1C less than 8.5, so certainly much higher than the generic target of 7. And a 1.5 difference in A1C is a 3-point difference in mean glucose. So, you know, this is taking the foot off the pedal to a moderate degree. Preprandial glucose is between 5 and 12. And prevention of hypoglycemia should be a priority. So again, here's the concept of balance. And so if you do have somebody with frequent hypoglycemia, they said you might even take the foot off the pedal a little bit more than that. Again, in elderly with cognitive impairment, which I assume is a fair chunk of your population, strict avoidance of hypoglycemia, and we'll talk a little bit about choosing your anti-hyperglycemic therapies.
Can I
Yeah.
comment about the 5?
Yeah.
My experience with frail elderly people, which is all I do, is I see a lot of people who even when they get below 7 to 6, they don't feel well.
Yeah.
Just like certain
Yep.
people need a little
So there's
so
there's certainly the concept, and it's not specific to the elderly, of relative hypoglycemia, right? So if folks are used to 10s and 12s and 14s, they will feel unwell at 5 and 6 and 7, right? Now, if it's important, you try to gradually dial them down. I think what this document is saying is if the patients are on low hypoglycemia risk drugs, and they run at 5 or 6 or 7, so if they're on metformin, maybe if they're on a gliptin, and I'll talk about that, you don't need to hit the panic button. Certainly if they feel unwell, if they're on hypoglycemic potential drugs, yeah, you might want to worry about it a bit.
The other thing I've mentioned is that the safety margin,
Agreed.
when you drop below 7, they may be okay at 6 or 6.5, but they miss a meal.
Agreed.
Yeah.
But again, you might lean them more up into the 8 to 12 zone, right? So again, 8 to 12 is still acceptable under this. And you're right, it's and it's alluded to, if they do have hypoglycemia, you certainly go towards the higher end. But you don't need to hit the panic button if they feel well at 6 point something. So the long-acting insulin analog, so here we actually got a grade B recommendation, so detamir and glargine, Lantus and Levemir instead of NPH. May help to lower the frequency of hypoglycemia. Mixed insulins, if folks are at home or if they're in assisted living and having to do their own, by giving them one type of insulin, they're less likely to mess up. I've seen folks, come out of, again, long-term care or assisted living, and they take 30/70 in the morning, and they take Humalog at supper, and they take something else at bedtime. I mean, you might as well just ask them to make a medication error. So they've got issues around dosing, and I certainly see that. But if they only had one type of insulin, at least they can't mess that part of it up. So at least they've got the right insulin. They can always screw up the dose. And unfortunately, insulin cannot be blister packed. As much as I would like it to be, it cannot be blister packed. There are some pens, interestingly, I didn't talk about it, but as I think about it, there are pens with little memory chips in them. So again, not for long-term care where the nurses are doing it, but for what I call sort of the pleasantly forgetful. It'll tell you when you took your last dose. So when you push the thumb down, it makes a little mark that, Agnes took 8 units at 7:30 a.m. And then if she goes and picks up her pen, at 8:15, did I or didn't I take my insulin? It'll say, yeah, you took 8 units at 7:30. It doesn't quite say it, but the implication is don't take any more, please. But again, if you're really demented, you're not going to know how to use those things. So again, there are some tools, but certainly insulin is a high-risk drug. Nurses mix up insulin types. So even if they're in long-term care, heck, even if they're on a medical ward on the Jubilee, I get a phone call, gee, doctor, sorry, I know I was supposed to give the patient 30 units of Lantus at bedtime. I just gave them 30 units of Humalog. So it happens. Again, Grady goes into geriatrician mode and talks about clock drawing tests in terms of who can or can't inject insulin. admittedly, in my world, I utilize the diabetes education nurses to tell me who can and can't, whether it's on an inpatient or an outpatient. They essentially do an OT type job on these folks, and they'll come back to me and say, you know, David, the patient can do this aspect, but not that aspect, and that's terrific. Lauren?
The pharmacare restrictions on
Yeah.
use of Lantus and
Yeah, but if they've had hypoglycemia,
yeah,
you
know
just write.
if they apply those restrictions also apply in the long-term care setting, or
They do.
yes, they do.
Well, if the patient's paying for their own drugs, right? They don't apply. Again, my experience is in acute care that, you know, I can prescribe them in acute care. So if the facility is buying the drugs, then I don't believe it applies. You can write up a special authority. Yeah. Yeah. Hypoglycemia on NPH, sign your name.
You have to try it first.
Yes. And the other thing, and it comes out in some other documents, regular diets, not diabetic diets, right? Undernutrition is probably more of a problem than overnutrition. I think one of the other documents. So, and truthfully, the diabetic diet these days is a healthy, balanced diet, right? I was laughing with a lady yesterday who, unfortunately, her pancreas transplant has failed after 15 years. And so I kind of had to re-educate her on all things diabetic. She hadn't been diabetic for 15 years, and she reminded me that, you know, 15 years ago everything was calories, 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 and now it isn't. So yeah, no significant restriction on diets. This is the American stuff, so this is fresh. The Americans do their guidelines every year. I like number one, and I come back to that. So older adults who are functionally and cognitively intact and have significant life expectancy should have the same goals. But glycemic goals for some older patients might be reasonably relaxed. Hyperglycemia leading to symptoms or risk of acute complications should be avoided. The Americans talk about other cardiovascular risks. Screening for diabetic complications, absolutely, especially those that lead to functional impairment, visual. And older adults with diabetes should be considered to be a high priority risk for depression screening and treatment. So I had to do a little cut and paste here to get rid of those stupid American units and put them in ours. So again, the top line, healthy with few coexisting chronic illnesses. The Americans have said less than 7.5, and then sort of scaling it up to 8. If anything, these guys are maybe a little bit more aggressive, but you know, they're in the range of what the Canadians have said. So 5.6 to 10 before meals, 6 to 11 at bedtime, and similarly, they scale up and down the blood pressure and lipid management, and you know, not quite the same nomenclature that Grady and the Canadians use, but fairly consistent. This is the most recent document I found, although it's about 4 years old. This is something that the European Working Party for Older People. The Europeans have the coolest way to name their committees. Working Party. And yeah, probably. Well, yeah, I won't be, you know, culturally insensitive, but, you know, some of our European friends like their vino. You know, screening and early diagnosis may prevent progression of undetected vascular complications. Overall improved metabolic control will improve cardiovascular risk. Screening for maculopathy and cataracts will reduce visual impairment and blind registration. So that again is, you know, the Americans talking about the importance of, you know, vision as something that will lead to impairment, and an integrated approach to peripheral vascular disease and foot disorders to try to reduce amputation rate. So again, a more short-term thing to focus on, and a good proper foot exam and proper foot care if required.
Retinopathy from the
A
time it's
decade.
clinically 10 years. So
A decade.
that's something like
So if they don't have retinopathy
Yeah.
today at the age of 75, they're not going to have vision-threatening retinopathy in the next decade.
And the same for the renal, it's even
Correct.
longer, isn't it?
I think it's about a decade. You know, if you have a normal GFR and you know, no proteinuria, it's probably at least a decade. So yeah, I do, you know, kind of amuse myself when, you know, I see, you know, markers of proteinuria being done on 85-year-olds. Now, you know, again, there are other vision-related issues that can occur, and you know, in my long-standing type 1 diabetics, you know, they're 65 years old, they have not a hint of retinopathy. Truthfully, they're not going to get it, and I say, congratulations, you're going to get old lady eye disease.
Yeah.
Right, but yeah, from a strictly diabetic perspective, with eyes and kidneys, we have at least a decade head start from a normal exam. Robert.
Among patients with diabetes, you know, type 2, a little bit of insulin, well controlled, they've had 2 or 3 normal eye exams. What's a reasonable interval between the eye exams?
From a strictly diabetic perspective, 2 years.
Okay.
You know, for other things like, you know, macular degeneration and cataracts and glaucoma, it might be as little as a year. But from a strictly diabetic perspective, yeah, 2 years. And it doesn't have to be with an ophthalmologist
Optometrist is good?
if they get it dilated. Yeah, yeah. I mean, I go to an optometrist and, you know, he blows everything up on, you know, TV screens this big. It's like, damn, I could be an ophthalmologist with that sort of technology instead of trying to hold the little ophthalmoscope. Actually, I sat on a panel with some ophthalmologists a few months ago. A guy named Dave Maberly from UBC. So, you know, first a family doc, admittedly from Toronto, came up and said, you know, I may look in an eye, but I'm kidding myself if I think I know what I'm seeing. And then I came up and I said, my name's David Miller and I don't even own an ophthalmoscope. And then Maberly told me that the dean is threatening to get rid of ophthalmology teaching at UBC because the family docs and the endocrinologists are going to teach the students how to do that. It's like, and we hadn't planned this. I mean, this was just strictly we were going down the line. So, yeah, as soon as I started working with an ophthalmologist, or I see what my optometrist does, it's like, damn, I got no game here. So yeah, an optometrist who does a proper dilated exam, you know, takes photos is just fine.
What I found is that I have to write the letters. I say, can you tell me what you've seen on the retina? Because they just say posterior segment normal.
Yeah.
But I've told them the patient's diabetic.
Correct. Yeah. Well, even ophthalmologists have a hard time writing in sentences, right? I mean, you just get this little code sort of stuff, right? I mean, occasionally you can get words out of them, but getting full sentences.
Vocabulary, though.
Well, they do.
Yeah.
They do. And I say to my patients, just, you know, did they say you had any diabetic changes? No. Fine. That's good enough for me. Yes. Okay. Now I need to see the report. Normal is normal. Abnormal covers a range. But yeah. And you know, it does take a little bit of personal knowledge sometimes of the optometrist. So, you know, if you've got one in the vicinity who gives you decent notes and you know is doing a decent exam, send your people to that person. Ted.
Yeah, Dave, I was just going to mention that, you know, part of it is screening.
Yep.
You know, people have no symptoms every,
Yep.
you know, geriatric perspective, you'd say every year or two.
Yep.
The other is a person has a sudden drop in vision. That's urgent.
Agreed.
And those people we don't send to ophthalmologists because they don't see people urgently. We send them to optometrists who will then see them immediately and see if there's been a macular hemorrhage or something like that, and they will get them into the ophthalmologist right away.
Good point.
So, pardon me?
MSP will pay for that.
Yes,
Yeah,
yes,
it's
absolutely.
totally covered, so if you send them with a medical problem, they don't have to
So,
pay for
so
it.
don't lose sleep over when we're going to get to see Dr. Short or whatever doctor. Send them to the optometrist. And in fact, call the optometrist and say, I'm worried.
Yeah, fair comment. The Europeans do give some specific recommendations for care homes. So they recommend, screening for diabetes at the time of admission. That could be as little as an A1C, right? We can now use A1C as diagnosis. You don't have to fast them. An A1C over 6.5 is type 2 diabetes unless proven otherwise. And then, at intervals, and CDA would say at least every 3 years. Each person should have a plan on admission. If they're on an insulin secretagogue and or insulin, you have to regularly review them for presence of hypoglycemia and optimal blood pressure and glucose regulation. The Europeans claim may help maintain cognitive and physical performance without a huge, grade of data. And finally, for frail patients, they talk about an A1C range of 7.6 to 8.5. If they have single system involvement, sort of 6.5 to 7.5 glucoses. And for frail, fastings between 7.6 and 9. So in some ways, the Canadians are actually the most conservative of the lot. And again, this is a huge document that I just picked a few things out of. This comes from the Europeans. So again, frailty criteria and different drugs for frail versus otherwise. So 3 to 6 months diet and lifestyle. Again, I don't know how much benefit you get from lifestyle if somebody's got a walker or can't get out of their nursing home. So, admittedly, I don't get a bunch out of lifestyle and folks who are supposed to be free living. Metformin as first line, and the Europeans say a DPP-4 as second line. So again, I know that runs counter to pharmacare rules, which say you're supposed to use a sulfonylurea and make them hypoglycemic. But if we just talk about the choice of drugs, a DPP-4 as second line because of the very low risk of hypoglycemia, because they're very well tolerated drugs, and then you can go up the scale. But this is the Europeans. They talk about lower risk sulfonylureas as an alternative, so that would be glycoside in one of its forms. Glinides, maybe not so much. They're harder to get. GLP-1 agonists, I'm not a huge fan of in this population. But again, trying to tailor the pharmacology and specifically trying to minimize hypoglycemia while getting a semblance of glycemic control. So that comes straight from the European document. Yeah.
Recommend for monitoring in nursing home.
We're going to get there.
One touch.
We're going to get there, Phil. Thanks for the plan. So this now I'm going to try to bring it together with some of my thoughts. So non-glycemic goals. So again, the endocrinologist gets accused of too many glycemic goals. Let's talk about some non-glycemic goals. So, a care plan with clear goals, proper diet, perhaps only minimally calorically restricted if they're obese, aerobic exercise if possible, resistance exercise if not, foot care, hypertension diagnosis and treatment, depression diagnosis and treatment. And then, the common comorbidities, or what I call the associations with diabetes that are not necessarily caused by diabetes: screening for hearing impairment, obstructive sleep apnea, fatty liver, low testosterone in men, maybe. Obesity is probably now the #1 cause of low testosterone in men, at least in terms of crossing my practice, and #2 is chronic narcotics. So, all the weird and wonderful stuff that we got taught in med school, like Klinefelters and all that kind of stuff, and pituitary disease, no. It's been totally trumped by obesity and narcotics. Periodontal disease, We now appreciate that certain cancers are more common in people with diabetes, or at least people who are overweight, bowel, prostate, lung, and breast. Prevention of fractures, whether those are caused by drugs or whether they're caused by hypoglycemia, and cognitive impairment is obviously a huge thing to keep in mind when we're setting goals. So yeah, I believe that the well elderly should have the same treatment goals. The frail elderly aren't going to get the long-term benefit. So not only, the 10 years around going from no eye disease to significant eye disease, truthfully, if you don't got 5 years in you, you're probably not benefiting from glycemic control. Your complications today are best predicted by your A1C 5 years ago, not your A1C today. But these folks are often admitted to hospital with vascular and renal complications. So if they've got pre-existing disease, it would be nice at least to try to stabilize it. And these folks are at increased risk of complications of hypoglycemia, including falls and fractures. So I believe the priority should be on the reduction of short-term symptoms, polyuria, incontinence, right? So if you've got somebody who's cognitively impaired and they're polyuric or nocturic, they're probably going to be incontinent, or they're certainly going to have a higher risk. And I believe that continence is a basic human dignity, and we shouldn't be backing off to the point that we're putting these people at risk. And increased infection risk. So this is my one cheat that Grady doesn't like. I think if you're over 70, your goal A1C should be your age divided by 10. So if you're 85, 8.5 is just fine. Truthfully, whether you're a well elderly or whether you're a frail elderly. And I do have a few patients, I'll have 74-year-olds with A1Cs of 7.7, and I say, well, if you just live another 3 years with the same glycemia, you'll meet my target, or we can work to get it a little bit better. But, it sort of slides it a bit, right? And the 70-year-old is more likely to have 5 years of life expectancy than the 80-year-old, who's more likely than the 90-year-old. And I take the foot off the pedal a little bit, and I say maybe 7 to 12 as pre-meal blood glucose.
David, I just want to ask you, what is the time to benefit for statins with a diabetic?
Probably 5 years.
So again, if you've got someone whose life expectancy is less than 5 years, because this is
without existing disease, right? If they've got existing
a lot of people
disease,
have it for a couple of years before it's undiagnosed, right?
Yeah.
Is that the feeling?
Yeah.
But it's about 5 years
It's probably
till you see
5
a benefit.
years.
Okay.
Yeah, that was always one of Yuri Froelic's rules. Yuri's the guru of lipids. He always wanted to start you on a statin 5 years before your dad had his heart attack. It wasn't a terrible rule, if you were a guy. So again, the Americans address that a little bit. If you're frail, if you've got multiple comorbidities, if you've got a lower life expectancy, they de-prescribing the statins. If they don't have much of a history that way. So yeah, my age divided by 10 rule does treat all elderly the same, but again, the patients seem to like it, and it actually makes a little bit of sense to me. So blood glucose monitoring. So in hospital, and I would certainly hope it to be the case in care homes, if the nurse thinks the patient's hypoglycemic, the nurse should just bloody well do a test, right? So in hospital, the nurse doesn't have to ring me up. They don't need approval. If something's going on, just go and do the dang test. The residents love it. In my clinical order set, there's a little tick box that says, check the patient at 3 in the morning. The residents always check that. I never do. Because I don't like getting woken up at 3 in the morning, and the residents maybe are here, and I say to them, if the patient's wandering around acting confused, the nurse is going to do the dang test anyways. Again, I get the frail elderly may have hypoglycemic unawareness. It occurs at both extremes of life. Small children won't tell you that they're hypoglycemic. Older folks won't tell you that they're hypoglycemic. So There's the concept of relative hypoglycemia, but there's also the concept of hypoglycemic unawareness. If you're going to start a medicine known to cause hyperglycemia, I think you should check their glucose, twice a day for a week. If you're going to start somebody on, 30, 40 milligrams of prednisone for their PMR, you probably should check them. To quote Chris Jones, I don't cause diabetes, I unmask diabetes. So, elderly folks are at high risk. And so you throw some steroids at them, you probably should check. If they're on oral medications and they're at target and they don't have hypoglycemia, no monitoring or twice a week, right? Just a little bit of what I call the canary down the mine shaft, right? Just so that, they don't all of a sudden show up and, suddenly you have an A1C of 10 across your desk. So really minimal sort of stuff. If they're not at target 4 times a week, maybe change their treatment. And once they get back to target, whatever that target is, then they can drop back, right? So pretty minimal sort of stuff. If they're on insulin, the rule is at least as often as insulin is given. So once a day insulin equals 1 test, 4 times a day insulin equals 4 tests. And I'll show you the tool for that. Yeah, Phil. Well, I still think for the hypoglycemic detection, right? Again, if they're just on basal, we're talking about 1 test a day. It's not around ensuring they're well controlled. It's around ensuring that they're not hypoglycemic. So that's where I come on it. So this is the paper tool from Canadian Diabetes. This is embedded within the guideline. There's also a dynamic tool that for some reason wouldn't print out for me. But if you go to the guidelines.diabetes.ca landing page, there's a little tool or app that says, pick how often your patient should check their glucose. And you answer about 6 questions, and it tells you and it shows you. And I built it, so. So, and again, not specific to the elderly. So the person with diabetes or the care team has to know how to use the damn glucometer and record the results, right? So before we do anything else, we got to ensure that. And then somebody's got to be willing to do something about it, right? So, the person, who's on metformin and, checks their blood 3 times a day and nobody does a damn thing about it, that's a waste, right? A good test changes what we do. So the must be met, and then we break it down into sort of green, yellow, and red. And what's my next slide here? Yeah, there's the guidelines.diabetes.ca. And then this document is actually the basis of the current pharmacare reimbursement policy. So people on diet or metformin or essentially low glycemic drugs can get 200 test strips a year. If you write a special authority, they can get 300. So if they're on metformin, they can't test every day. They don't need to test every day. And so what I wrote with CDA is that those people could test up to a maximum of 15 times a month. Pharmacare rounded that up to 200 a year. Fine, right? You can't buy 15 test strips. You got to buy them in aliquots of 50. If you're on a drug with hypoglycemic potential, i.e. a sulfonylurea, we said once a day. Pharmacare rounded that to 400 a year. Fine. Again, you can get them a single exemption for an extra 100, but that's it. People on insulin have no limits, regardless of the type. At one point, Pharmacare wanted to try to distinguish between who's a type 1 and who's a type 2, and I said, you guys can't do that. Don't even try. So they didn't. So as a practical perspective, no, I don't think the person who's just on basal insulin should test as often, and this doesn't say that they should, but from a policy perspective, once pharmacare sees a single purchase of insulin, they go to the 3,000 test strip limit, which is 8 a day, which some of my type 1s do exceed. But I would think that nursing home patients shouldn't.
Okay, I was just going to say, I think probably the most important testing in this population is to flag the charts, to say this person was diabetic on oral hypoglycemic,
Yeah.
or insulin, so that the LPNs, the care aides, know if there's any change in their function,
Yeah.
any confusion, any delirium, any fall, test or trigger.
Right.
That's been my, because
but I don't know what the policies within the different homes are. I mean, that's on you
as
guys
a doctor,
who work there.
you can write an order
Okay,
saying if there's any deterioration,
just do a test.
immediately
Yep.
check the blood sugar. Because
Yep.
some of these people are left, they say, it's a UTI.
Yeah, fair enough. So yeah, so we walk through this. Again, we say it's probably not that relevant. So if they're on multi-injections, if they're on a pump 4 or more times a day, insulin less than 4 times a day, at least as often as insulin is given, pregnancy is probably not an issue. Starting a new medication known to cause hyperglycemia, experiencing an illness known to cause hyperglycemia, you could and should test a little bit more. But the numbers for pharmacare that you guys need to keep in mind are 200, 400, 3,000. So, the recommendations that I, gave you back here, again, if they're on target, they've got little risk of hypoglycemia, 0 to 2 a week is, significantly less than the 15 a month.
You say that you've got somebody who may be starting steroids for a certain amount of time, maybe it's a week, maybe it's longer, and you want to test them twice a week, times 1 week. What are you going to do with that information, and when do you intervene?
Well, if they get up into the symptomatic zone, yeah, then you probably want to do something about it. Maybe you want to start them on a sulfonylurea. Again, it's going to depend a little bit on how long they're going to be on. So in the example of PMR, it's months to a year, right? On the other extreme of my life, the ladies who have prem labor and get 2 doses of betamethasone 6 or 12 hours apart, I ignore those ones. I know they're going to go high for 2 days. I just ignore it. But, if the plan is that your folks are going to be on steroids for months, you ought to do something about it. Admittedly, the worst offenders lately are the oncologists who think, 40 milligrams of dexamethasone is candy. and I regularly get, called about those folks. And these cyclical dexamethasone programs, they're just the death of me. One of my best stories, a guy's getting treated for bowel cancer, and he's told, well, as you get into sort of cycle 5 or 6, you're going to get some gingivitis, you're going to get some stomatitis. Why don't you just suck on some popsicles? The guy's not known to be diabetic. Oh, by the way, his sugar was 30. So, that's just, so a little bit of screening in that situation. I had another guy who again was being treated for bowel cancer. I forget why he went and saw Gary Nielsen for some reason, and Gary poked his finger and it was 30 again. He was getting cyclical dexamethasone. Gary sends him to Emerge, where he got a little bit of grief from the Emerge doctor, believe it or not. On the Thursday, not you, on the Thursday before the Easter long weekend, and not only did he have a sugar of 30, he was so lipemic that when the RT took the blood gas, you could see the fat in the whole blood, and he had trigs over 200. Not known to be diabetic, not known to be dyslipidemic, 40 milligrams of Dex, with his chemo, no pancreatitis. So, a little bit of screening, and, if you're going to treat somebody for a period of time. If it was just a pulse, if you're just going to give them like 7 days for an asthma flare or a COPD flare, fine, don't worry. But if it's going to be months, I think you need to look. And I don't think you want to wait until you do your annual A1C on these people. Right? You can start with a sulfonylurea, but if they are on a fair whack of insulin or a fair whack of steroids, they're probably going to need insulin. And the prednisone folks, again, it's not part of this. The prednisone folks actually often do well with just a single shot of 30/70 in the morning, because the prednisone and the 30/70 overlap each other quite nicely. Right, so that's that one. So here, I'll just bomb through. So oral medications with lower side effects, including hypoglycemia, max tolerated metformin, glycoside acarbose DPP4s, stepped approach to insulin, never a standalone sliding scale. Analogs can be used as second line, as Lauren alluded to, where hypoglycemia should be uncommon. So here's the list. I show the med students. This is the current list of all available non-insulin drugs in diabetes. Not a fan of glyburide, not a fan of TZDs because of the fluid retention and the heart disease. Probably wouldn't use a GLP-1 analog. And as much as I like the SGLT2 inhibitors in younger people, because of the polyuria, polydipsia, dehydration, not a fan of them in older folks. So that's your canagliflozin, dapagliflozin, soon to be empagliflozin. Wouldn't go near them in a nursing home population. But the non-glyburide sulfonylureas, sure, metformin, sure, and DPP4s. I don't use a lot of acarbose, but it's a safe drug.
And your pharmacare policies will...
Say you got it. Well, but you could go glycoside, right? You could go metformin, glycoside, and DPP4 as a third line.
So you're accepting glycoside in that
Correct.
class of drugs,
Yeah.
but not the others.
Not glyburide.
You need to have hypoglycemia and glyburide to qualify for glycoside, unless that's been changed in the last year.
We're working on it. And
You need to have hypoglycemia.
You need to get sicker
Yeah.
first.
Yeah.
But the difference in cost is about
Even though
$3 a month.
That's
I mean,
ridiculous.
the out of pocket. So we're working on that one.
Yeah.
So here's the summary. I like this. So patients with advanced diabetic complications, life-threatening comorbidity, or substantial cognitive or functional impairment, reasonable to set less intensive goals. These patients are less likely to benefit from reducing microvascular complications, more likely to suffer serious adverse effects of hypoglycemia. However, patients with poorly controlled diabetes may be subject to acute complications, including dehydration, poor wound healing, and hyperosmolar coma. And glycemic goals, at minimum, should try to avoid these consequences. Mike?
Just regarding the metformin quickly, just the GFR threshold, because most
30.
people 30, so you're comfortable down to about 30?
Yeah. Yeah. I should. The other thing with the DPPs, again, there's some pharmacare things. They've delisted sitagliptin. Saxagliptin comes in 2 doses. Linagliptin is a single dose regardless of renal function. So 5 milligrams of linagliptin, you don't have to think about it. And it again can be dosed down to GFRs of 30.
Just with regard to what Mike is saying around the GFR, we're GFR not creatinine clearance the way our pharmacies can calculate using the copper.
Yeah.
It's always different.
Yeah, which one do we? Yeah, just whatever the lab spits out
The lab
as the eGFR
Okay.
of, most of us are comfortable down to 30. I should have mentioned the other one is the sick day management, which I don't do enough of. But, John Antonsen will tell you that he'd be happy to dose metformin in dialysis patients if he had complete control over what drugs patients did or didn't take. So it's probably not just the low renal function, it's the low renal function with a second hit, which is usually a dehydrating illness, right? So the SAD man, sort of drugs, the ACEs, the ARBs, the diuretics, the metformin, SGLT2s are on the list, and non-steroidals, the stuff you're supposed to hold for 2, 3, or 4 days if they have a dehydrating illness. Those are the folks who get into trouble. And again, operationally, I'm not quite sure how you folks deal with that. I'm not great about talking about it. I'm trying to do better. Because again, those are the folks who get in trouble, right? They're sick, they're puking, but God bless them, they're still taking their ACE inhibitor and their Lasix, and those are the folks who land on Rod's department, and then the stat call to John because they've got a potassium of 7.5 or some sort of nonsense like that. So those seem to be the people who specifically get into trouble with metformin, but because we can't control each and every pill that goes into our patient's mouth, the EGFR of 30 is generally considered to be safe. I'm fine. I'm almost got you guys back on time, but I'm happy to take. You got 7 minutes. Okay. Bill.
Can you just recommend a simple, effective regimen for insulin for most?
Yeah. So again, if it's basal insulin, you start at a ridiculously low dose, and then you just titrate up accordingly. Again, at home, we can teach the patients how to do that. With you folks, I assume you just have to write a new order, every sort of week or so.
Is it BID 3070?
BID 3070, my recipe is you go 0.3 to 0.5 per kilo, and you just split it 50-50. So in a younger person, 80 kilos, 0.5 is 40, you go 20-20. Maybe in an older person, maybe you want to go sort of 0.3 per kilo. You want to be a little conservative, so you go 12 and 12 as a start point.
In case of a hemoglobin A1C of 1.
9.5, or somebody who's failing basal insulin only, right? So the ones I see, you've titrated their basal insulin, their morning sugars are great, but because they're rising through the day, they're symptomatic overnight, or they've still got a high A1C. So again, the sort of stepped approach to insulin, start with basal plus orals, then go to BID premix, and only in exceptional cases, including type 1s, would you go to QID. I guess that's, again, one of my other sort of things I didn't put in here. Type 1 diabetics are now living to nursing home age, right? The whole idea, I have people, they've been diabetic since 1960, and I say to them, listen, you didn't exist when you were diagnosed, right? There was nobody walking this earth with 50 years of type 1 diabetes in 1960. Hell, there weren't there in 1970 either. So the whole idea that these people were going to die of kidney disease and be blind is not necessarily the case. So, I also have the same discussion with 50-year-old ladies with type 1. It's like, yeah, we don't know a whole hell of a lot about menopause in type 1 because this is a new concept. So, type 1s are going to be very fragile. They're going to be all over the place. One of my pet peeves, I think I alluded to this when I was prepping with Ian, I occasionally get a request, please simplify, i.e. take this type 1 back to BID 3070 because they've got erratic blood sugars. Taking them back to BID is not going to make them less erratic. It's going to make them more erratic. So again, as these folks live to nursing home age, there's a small percentage of folks who do need QID insulin.
When you talk QID, are you talking basal and TID bolus?
Yep.
Yeah, I was just going to say, David, from a geriatric perspective, in the American Geriatric Society, they, number one, recommend avoid mixed insulins because of the higher risk of hypoglycemia. Okay. And most people you can cover with NPH. You don't need the added.
Sure, yeah, but if they don't,
but I'm saying the vast majority of diabetics are type 2, right?
Yep.
The vast majority of people you're going to see are type 2. The second thing they say is there's almost zero place for a sliding scale, except for
on top of QID.
Except for the people, like you're saying, which is a tiny minority of people who are type 2 for many years and their pancreas poops out.
Yeah,
And they
absolutely.
become
Right.
type 1. These are
Right.
people, their sugar's still
Yeah,
going 20s,
Right.
30s.
And that's where in hospital we call it a correction.
Yeah.
Right? So if they're already taking bolus insulin 3 times a day, you can add or subtract a little bit from that. But the standalone sliding scale, that should be gone.
And the problem we run into is people get discharged, they're ill, and they need extra insulin. They get discharged back to care on a sliding scale. And I think most people would recommend go back, put them on NPH, put them on Lantus,
Absolutely.
get rid of the sliding
Absolutely.
scale, and get them into the reasonable target.
Correct.
Right?
Absolutely. So yeah, one of my efforts in hospital is to get rid of them in hospital.
Yeah.
Because it's bad in hospital, and then hopefully you'll see less of them coming out. And it comes to the monitoring. I mean, if you're going to truly do just a sliding scale, you got to monitor them 4 times a day, right? And I want you monitoring less, not more, with the exception of these folks. But I guess just the corollary to that is you're going to see more and more type 2s who are functionally type 1s because type 2s are getting it younger. Right, and they're going to be functionally type 1s.
Practical perspective, being in the biz, the tip-off is they start losing weight. These people, they are sick. And you see that, they're old, why are we going to chase their blood sugar? But when their blood sugars are in the 20s, these people are sick, and they get weak, and it's not just the dehydration. They're
Correct.
They're
Well,
sick.
they're
In a
catabolic.
state.
Absolutely, right?
So-
And then they're losing muscle mass, and again, all those things that you're supposed to be against are what are happening. But yeah, unfortunately, you are going to see more and more type 2s who look like type 1s.
David, what do you have to say about someone who has really erratic blood sugar, so like 9 to 20 something, but the A1Cs are, for this
Don't
particular
test.
individual are not so bad, kind of roughly acceptable. This is someone who refuses to give up his
Yeah, there's nothing you can do
junk
about it.
food
Yeah,
and
Just how hard do you chase it?
yeah,
hardly,
Yeah,
I guess that's my question.
yeah.
Not eating like a bird.
Symptoms.
Symptoms. Yeah.
Okay, so if A1Cs are not horrendous, then
Yeah,
whatever.
you just roll with it.
Okay.
The other thing that I found challenging just with the startup of this program and getting to know the patients is that when the patients who are diabetic get sick and their sugars are 15 to 20 and they've usually been 8 to 12, and it's hopefully a short-term illness, the nurses are calling
I
them
know.
a lot
Right.
because of the numbers.
Sure.
And what do? Do you reassure them that should be okay, or do you chase them around with their insulin pen? So that's what I feel like I'm doing. I'm chasing the patients
Yeah.
because the nurses are.
Well, I mean, when I get those calls, the first question is always why, right? Because I can always give more insulin. The question is why. The last one I got, well-controlled guy, all of a sudden he's got sugars up in the teens. Well, he had just gone home a week earlier from his cabbage, and he in fact has a rip-roaring sternal mediastinitis, and has now spent a month in Jubilee. But the canary was his high blood sugar, right? So yeah, again, in hospital, maybe it's because the family brought something in, maybe it's because they've been to Tim Hortons, but maybe something's going on. And so the first question is always why. So if it's that dietary non-compliant patient, just throw your hands up. And sort of set your call parameters probably pretty wide. Right? We say in hospital we probably don't want to get called until the blood sugar is 18. But I don't say 30. Right? So it's just kind of where you set the parameters. But if the patient has pneumonia, you've got them on a proper treatment course, probably to again just try to roll with it.
So you don't need to treat those in particular.
Probably wouldn't. But it is the two-edged sword, right? Higher sugars predisposed to infection. Sometimes the sign of infection is higher sugars. In hospital, we chase them. Oh, here, two last ones. So the young lady in the back, and then we'll finish with Laura.
Somebody who's coming in at a facility on metformin and glucoside,
Yep.
max doses. I switched somebody over to basal insulin, but then I felt like the sugars really and stopped the glucoside. But I wasn't sure,
Yeah,
what to really
that's the
do.
eternal question. I probably would just cut it in half. Just
So
cut the
leave it
glycoside in
there.
half.
Okay.
And then again, then you've left your wiggle room in both directions. But yeah, I probably wouldn't have stopped the sulfonylurea
Okay.
in that situation. Now if they're on BID 3070, you stop the sulfonylurea. Right? Once they're on insulin through the day, there's no benefit to the sulfonylurea. But if they're just on basal, they probably need a little. Right? Because again, if you're giving them insulin through the day, it doesn't make sense to give them an insulin secretagogue. But if you're giving them basal to fix their fasting, they still may benefit, especially if the basal's NPH and is going to crap out after 12 to 15 hours.
And so then I started adding a dose in the morning, and then now
Yeah.
it's a bit crazy.
There you
But
go.
do I leave the, like, if they're stable, they're, you know,
Yeah.
hemoglobin A1C's 9, do I actually make any change or just
Probably not.
Probably not, yeah.
Probably not. Lauren.
Oh,
Bring us home.
When I moved from basal only to basal plus bolus, do you recommend testing before and an hour after meals or just after meals? I think my target is we want to control the postprandial sugars.
I'll sometimes even just wait till the next meal. Like if you're giving them, you know, just short acting at supper time, I think there's going to be too much, you know, I think it's too much of a work burden to do a 1 or 2 hour post. I'd probably wait until HS.
Okay.
In a nursing home situation. In a home situation, you can maybe to get them to do a 2 hour post,
Yeah, that's what I usually do.
but the work burden of doing testing at non-standardized times, I worry about.
Thank you.
Thanks, guys.